Hello, Dr. Sharma. I am so sorry if we do late. Hi, how are you? I cannot hear you. Please, I will unmute your speaker.
Hi,
Yes.
you can listen me now?
Yes, now I can hear you.
Okay, very
Sorry,
good.
I'll just start talking with you direct. I will present you to our audience and I will let you the speech, but I will present as in Arabic language.
Okay,
How
okay.
about Arabic language with you? You have
Actually, I'm so sorry. I don't know Arabic speaking, but I can speak in English.
Yes, sure. I am here also with you in English. I will just present you first and I will let you to talk. Okay?
Okay, okay.
أعزائي والحضور جميعا أشكركم جدا على متابعتنا وعلى المحاضرة القيمة لأستاذ أحمد حبيب اللي ودتنا فعلا في اتجاه له علاقة بالبزنس، ولكن كما كان تعليقي عليه الألوان والإضاءات ده من العلوم المختصة التي لها علاقة كبيرة بالأوبتكس والبصريات. دلوقتي احنا هنروح لمرة أخرى لتخصص العيون الاصطناعية، ولكن هذه المرة من زميل غير عربي وهو مستر شارما، وهو من الهند، حاصل على بكالوريوس الأوبتومتري، وهو هيتكلم معانا النهارده عن الجديد في العيون الاصطناعية وهو بيسموه الأوكلاريست. أنا طبعا يعني بقدمه بالعربي، لكن هو زي ما انتم شفتوا هيتكلم بالإنجليش. بالنسبة للزملاء اللي الإنجليش بتاعهم يعني مش هيسعفهم في فهم المحتوى، ما يمشوش وما يروحوش، لأن في محاضرة بعد مستر شارما باللغة العربية للمستر أو الدكتور ماهر سليمان بلوط من فلسطين، وهيتكلم معانا عن حدة الرؤية، وده من أهم الموضوعات اللي أخصائي البصريات لازم يبقى عنده كل التفاصيل عنها. فأرجوك هنتابع دلوقتي مستر شارما، وبعد كده هنتابع Mr. Maher Sulaiman. Mr. Sharma, please,
Yeah.
you can start sharing your screen, and we are
Okay.
so happy. We are thank you to join us in our international optics in first conference in Egypt.
Thank you
Thank you,
so much.
Mr.
I'm so happy to be with you. Thank you.
We too. Thank you.
Yeah.
You can start.
Yeah. So, hi everyone. This is Ravikant Sharma, an ocularist. And thank you so much for giving me this opportunity to present in front of you. So my presentation topic will be I make what's a new in ocularistry. So I'm an ocularist based in Delhi. Hello? Hello?
Yes, you can continue. We are with you.
Okay. Thank you so much. If I'm little speedy, then please help me so that I can go slow. Okay.
No, we want you to go fast actually because we have short time.
Okay. So first of all, this is artificial eye is a non-functional cosmetic replacement of affected eye, and a person who fabricate the artificial eye by taking an impression of the socket and cosmetically rehabilitate the patients called an ocularist, and the process of fabrication is called ocularistry. So my presentation will be case-based presentation. I'll present my 4 cases. One, ocular prosthesis with shallow fornix. Second one will be thin scleral shell. Third one will be partial orbital prosthesis. And the fourth one will be management of microphthalmic or anophthalmic patients. First of all, we will go with the ocular prosthesis within the shallow fornix. This is the patient who is 40-year-old male, having the history of glaucoma. Because of glaucoma, he lost his sight and he was having a lot of pain. So then he got the evisceration done. While when he was presenting to me, socket evaluation was perfect and he was having healthy socket, but compromised the lower this. I'll just show you, annotate and okay, this. So this is the portion which is very shallow. Sorry. This is the portion which is very shallow here. So the normal or the conventional impression trays were not fitting into. So I designed the impression tray by keeping in mind 2 design of soft contact lenses. Being an optometrist, it is actually very helpful for ocularists. So there are two technology which are being used making toric contact lenses. One is prism blast technology, where the weight always remains at 6 o'clock position. So the axis remains at the same place where it is being prescribed by the optometrist or the ophthalmologist. The other design is Asd Design, which is being followed by Johnson & Johnson for making toric contact lenses. So I kept this design actually in my mind. So I designed an impression tray basically to reduce this Fornix's area here. As we can see in this picture, here this is perfectly all right at 9 o'clock and 3 o'clock at the medial canthus and the temporal canthus here. But here I just reduced the impression tray for making little bit of space just to rest, not much. If I made it like this, then it would have been difficult situation for me because already it is shallow Fornix. So you can say the impression tray could not be held in the Fornices. So I reduced the impression tray and I made it actually this technique in my mind, which is being followed by Johnson & Johnson for making contact lenses, toric contact lenses, where the weight always remains at 3 o'clock and 9 o'clock position. So I took the impression. This is how I took the impression. And then the wax model was tried in his eye and he's absolutely fantastic. He's comfortable with it. And this is how it comes actually when I made the artificial eye for him. And there is a small video where we can see the how his retention is there in the socket. So the artificial eye doesn't pop out. It is perfectly fine and retained nicely in the socket. So this is how it comes actually final product. And the second case will be thin scleral shell. This is the patient who was having a little bit anterior staphyloma. I asked him actually to get the surgery done, or evisceration or enucleation, but unfortunately he was not ready to get the evisceration done. So I convey him all the ifs and buts and do and don'ts about the scleral shell. So I just asked him to design the conformer. Scleral shell was planned. Impression with the alginate was done. And I asked him to use customized conformer for 1 week. First 3 days removal at night so that he won't have some kind of pain and he will have comfort actually with it. And then advised later on like 3, 4, 5 days to sleep with it, the conformer. Conformer evaluation against any type of shortening medially and laterally. If found, then the size of the conformer increased with the wax and altered accordingly. Socket evaluated with the conformer against any kind of blanching of blood vessels. So this is how I designed the impression, and this is the conformer, customized conformer, which is being put inside the socket. But I found there is a space here medially. If we see the medial canthus here, there is a gap here. So what we did, we just increase a wax model here a little bit, and then we design this conformer again, and we put the patients with the conformer. But in this, being an optometrist is actually very helpful because scleral contact lens technology helps a lot here. As we can see here, by putting this whole side big conformer, there is no blanching here. The blood supply is perfectly all right. I can see there is a small air bubble here. So I just to get rid of this air bubble, I just ask patient to use lubricating drops, but with the little jelly kind of, so that this air bubble fills up. And this is how I designed the white conformer. This is even 100 microns thickness, less than the scleral contact lenses. Then I paint it, and this is how it comes. Like you can say this is less than 500 micron thickness of the artificial eye, or you can say the scleral shell. This is 500 microns here at the center, and even less than 500. It is approximately 200 at the medial side.
Dr. Sharma, sorry, if we can end with this case.
You want to end it?
With this case.
Okay. This is less than 1 gram, and
yes.
This is here, the prosthesis, how it looks. This is the final outcome of the patient. And this is a small video which gives us idea about how does it feels. Okay, this case is end here, and these are some other cases which I treat according to the same technology. And this is partial orbital prosthesis. This is the third case of mine which I'll present in front of you. This man was electrocuted actually, high voltage electrocuted, so the half face was burned totally. Then I asked him to use the prosthesis, but he was ready to use the prosthesis, but he said something has to be done for the, or these lids actually. He lost his upper eyelid completely and the partial lower lid. So I designed the prosthesis according to this design, and this is how it comes actually for the design. The upper eyelid completely I designed, and the lower lid I designed half. And this is how it comes when I make the prosthesis for him. It totally incorporated in the artificial eye, and the lid also made of acrylic here.
Wow,
and this is the
amazing.
outcome of the patient. These are some cosmetic rehabilitation with these spectacles so that he looks comparatively better. And this is another girl with partial orbital prosthesis, where the lower lid I made it completely and upper eyelid made it slightly, partially. This is how it comes for the. And this is microphthalmia and anophthalmic patients. 2 patients I managed with conventional technique by only just doing the socket expanders. History patient noticed about, the parents noticed about the follow-up with the nearby ophthalmic clinic, then referred to my clinic. And in these cases, ophthalmologist, ocularist, and parents, actually, this is very much necessary to tell them how the follow-up is going to be crucial. If they miss the follow-up, then you cannot do anything about it. This is how it comes. This is microphthalmia case. And I started with a small size of conformer, then I increased the size, and then I increased the size, and then I found it like this. This is the final outcome of the patient. And this is the anophthalmic patient. But I would like to just share you one thing. In microphthalmic patient, I actually found it easy to maintain, easy to manage. How? Because there is a defined shape of the eye. I know there is a small size of the eye, but there is a defined shape. So we can take the impression comparatively much better as compared to the anophthalmic socket. So in my opinion, microphthalmia is comparatively easy to manage as compared to the anophthalmic sockets. In this anophthalmic case, I got this
Dr.
girl
Sharma.
around maybe 4 months or 6 months. Then I
Dr. Sharma, do you hear me?
Sorry, yeah, I can hear you.
Actually, I want really to thank you very much. You are amazing. All your cases you present to us, it's very wow. All our audience in chat, they are thanks you too much, and they are telling you it's wow and super. And really, we are amazing because as we are not too much familiar to ocularist in Egypt, so
Okay.
this was a awesome presentation on your work,
Okay,
and
okay.
it's also showing you are very clever in this work. Thank you very much for you. So
Welcome.
any end words you would like to add?
So it was actually very nice experience with Egypt Optometry Conference. So I'm very happy actually to present my work here. But I'm so sorry, actually, I couldn't complete my presentation, but no problem.
We are so sorry, not you, because this is our problem, our time. We are so sorry for that. But really, we will organize another connection or relation between us and you. We are seeing too much potential in our colleagues and audience for contact you more. I would
Okay.
like to thank you very much. Thank you,
Thank you
Dr.
so much.
Sharma.
Thank you.
Thank you very much. Thank you.